some landmarks here, okay? So we're going to start with the suprasternal notch. This is right here. Thank you. All right, we have our trachea, right? There's no deviation. Suprasternal notch. Angle of Louis is right here. It's like that little line. If you need to pull up your slides from this week, or where it shows the ribs and where you listen, it's that little line right here. You can actually feel it, okay? Suprasternal notch. Let me make sure I'm going in the right order. I don't want to tell y'all something wrong. Yep. The costal angle, right? This is literally the bottom of your ribs, okay? Right? And then also we're going to inspect C7 and T1, cervical vertebrae, okay? We want to palpate those. Is there any deviation, abnormality? Because we talked about kyphosis or gibbous, which is the extreme humpback, okay? But we want to know, how is all this lined up back here, okay? So, suprasternal notch, angle of Louis, costal angles, C7 and T1. Just kind of walk your fingers down the spine. Tenderness, deformities, abnormalities, okay? So then, we're going to move down. We've already noted, is there any kyphosis, lordosis, scoliosis, all those abnormalities of the curvature of the spine? Again, they're sitting up, we're just looking. We'll assess that again for musculoskeletal. So this is like the first time you see it, okay? And then we're going to do thoracic expansion and tactile fremitus. So Bradley, I'm going to have you stand up and turn around. So for your patient, you can have them flip around on the exam table, okay? So thoracic expansion, I want to see if their chest expands equally on each side with each breath. So how do I do that? I'm going to encircle his ribs at about the 10th rib. You see how my hands are, my thumbs? I want everybody to be able to see those, okay? He's going to take a deep breath, and I'm literally going to watch and see if my thumbs expand and contract equally, okay? So take a deep breath, and back out. Good. And there was equal thoracic expansion. Not a hard test at all, right? Okay. Then we're going to do tactile fremitus, and this is for vibration. Remember we talked about vibration. It should be a normal vibration, but if it's really, really loud and palpable with the ulnar surface of your hand, what could that mean is in the lungs? Fluid or mucus consolidation, right? Just like we do vocal resonance. If it's really loud and clear, we can assume there's something in there. Or if it's really soft, there's a lot of air in your lungs. It's not transmitting those vibrations very well, okay? So with the ulnar surface of my hands, I'm going to walk it down his back, the posterior aspect, and he's going to repeat the number 99 as I touch his back, okay? Say 99.
99, 99, 99, 99.
Okay? So I did feel a vibration, but it wasn't really strong or like heavily felt, okay? So that's tactile fremitus. Do I need to show you guys those two again? No? Okay. So, then we're going to move on to percussion. So have you been practicing your percussion techniques? Everybody says, yes, Ms. McCraw, we have. We have percussed our computer, we percussed our desk, we percussed our friend. Right? Okay. So, it's a strike of the wrist, right, onto that distal joint. The whole point is to send that sound and vibration through and pay attention to what you get back out. So what should I hear within the lungs? What sound? Starts with an R. Resonance, meaning there's air in there, okay? If it's flat, what might I be actually percussing? Bone. So we want to go into intercostal areas. And we're going to have them cross your arms a little bit. See how that opened up his scapula? So we really are getting the lung fields here, okay? If it's dull, what might I be over? Organs. Or there could be some consolidation in here. Tympani is in the abdomen, okay? If it's hyperresonant, a very loud air-filled sound, what might that indicate? Too much air in the lungs, which is what disease process? COPD, emphysema, right? Okay. So we're going to percuss. Remember, there's 10 areas on the posterior aspect. We want to go side to side and compare upper to lower in what we hear, okay? So we're going to percuss down the back. What I just talked about was pitch, tone, and all of those things that are listed there. So you would just talk to your patient and say, I'm going to percuss. I should hear resonance throughout your lungs. I should not hear flat. That could be over a bone. And dull would be over an organ or if there was consolidation, okay? And guys, please remember to talk to your patient as you say this. Yes, we are listening on the camera, but this is getting you in the routine of patient education. Because sometimes they want to know, what are you doing to me back there? Educate them, okay? So we're gonna percuss. I know you guys can't hear it, but I can, and it's resonant, okay? And that really does take some practice, and I should have reminded you guys to cut your nails, because you're gonna hurt yourself, or if you slip off like I did, you could scratch your patient. Sorry about that. Okay. So I percussed all the way down. Now I'm gonna do diaphragmatic excursion. This is the fun stuff, okay? So literally you are seeing how much their diaphragm moves with each breath. Talk about x-ray vision, okay? So remember what the diaphragm is for. It's that large muscle, okay? When we breathe in, it goes downward. When we breathe out, it comes back up. So this is the part that's going to take the most skill for you today, okay? You should all go away from here today with marks on your back. Now, I said one side of the diaphragm would sit a little higher than the other. What side? Why? The liver lives in there, okay? So think anatomy. Whew, anatomy and physiology, it's never going to go away. Neither is patho, okay? So we're going to start, and you have them taking a deep breath and hold it. Then you want to percuss from about the 5th or 6th rib down, listening for the change from resonant to dull. Then you put a mark. Have them breathe a little bit. You're not holding your breath, are you? Okay. Thank you. Because I'd have to let you fall. Just saying. So then, when they breathe, then we want them to breathe out and hold their breath. So the first breath they breathed in, the diaphragm fell low. We mark it. Then they're going to take in, breathe out, and hold it. So the diaphragm has moved back up, and they're holding it there. So you're going to percuss back upward from dull over the diaphragm till you get to resonant over the lungs. Then you're literally going to see the space between. How much did their diaphragm move with that breath? Should be 3 to 5 centimeters, okay? If it's a little less, we might think lung disease or something like that. If it's a little more, we want to look at, are they active? Are they an athlete? Do they swim? Things like that, okay? Or do they have another chronic lung condition where they're trying to take in deeper breaths to move more air, okay? So I'm going to show you that in real time what that looks like, okay? So taking a deep breath and holding. Breath and hold it. Breathe out and hold it. Breathe out and hold it. Okay. I'm not sure if this marker's going to come on. So, centimeters, not inches. And he is at 4.5 centimeters. How cool is that? We know where his diaphragm lives and how much it moves. Look at that, x-ray vision right there, okay? But you really have to pay attention, okay? Your exam, you want me to take a picture for you?
I'll see it on bread.
Your exam room needs to be quiet. Just like in your room in the hospital, if the TV's blaring or they've got music or the family's all talking, can you please quiet down? Can I please turn the TV down? I need to listen, okay? You have to listen and make sure you can hear the change from resonant to dull and dull to resonant, okay?
And Ms. McCraw, when you're making those marks, if you're drawing it on top of your finger, make sure the second mark is on top of your finger also. You don't move to under your finger. I've seen students do that.
Thank you for that. I was going to remind, thank you, because that's going to mess up your measurement, okay? So when you percuss downward for that inspiration, and I'll draw above. When I percuss back up, I'm gonna draw above. Like I have red marker on my fingernail where I drew on both sides. You can use a pen, like a writing pen you're using right now, or a marker. It doesn't matter which one, okay? Today, I want you to practice on the right and the left, just to get more practice in, okay? Practice multiple times. Make sure you can hear. Now, when they're on the exam table, if you lean them forward a little bit more, it really opens up everything and you can hear a lot better, okay? Everybody somewhat clear? Yes, ma'am?
Just a polite thing, ask your patient if you can mark on them. No one wants somebody to whip out a Sharpie on an exam table and write on them. You're gonna feel like a piece of meat. I mean,
Yeah.
you know, just politely get used to asking that, because in the clinical setting, that is very demeaning for somebody to just whip out something and start marking.
Thank you for that. Yes, we always want to respect our patient. And there's ways that we can mark without literally drawing on them. You know, with your gloves on, you can kind of rub the skin a little bit. That'll leave a little bit of a red mark or something like that. So we have ways of doing that without actually marking on you, okay? So that's your diaphragmatic excursion. Then we're going to move on to auscultation, okay? So we're going to do those same 10 points on the posterior. There's 4 on each lateral aspect, and then 10 more anterior. Now remember I said don't get really caught up in, well, number 1 has to be here, and number 2 has to be here. The point is, I want you to listen to each and every lobe of every lung. You have to make sure this is a thorough assessment, or you will miss something. Think about pneumonias and fluid. Where does gravity make that settle, usually? Lower. So if I just listen up here, I know nothing about what's going on in my lower lungs. Or take into account if your patient is bedridden and they lay back all the time and you think they've aspirated, might they have aspirated somewhere higher because of how they're laying? So take that into account. That's why we listen to all lung fields, okay? For 1 full breath cycle. Don't be afraid to give your patient a little bit of a break. Don't rush them through this. All of us have been in the doctor's office when they're like, okay, breathe in and out, and in and out. And then you're like, I'm gonna pass out, okay? Let them breathe on their own as they breathe in and out. Listening for inspiration, that pause, and expiration. But also noting adventitious lung sounds. Crackles, which might indicate fluid, like congestive heart failure. Rhonchi, that really loud snoring sound, that might indicate consolidation or pneumonia or a foreign object in there, okay? The friction rub, that leathery rubbing, if they have pleurisy or something like that. Wheezing, I'm like, what's the obvious one? Wheezing, that high-pitched musical sound. Also note where you hear it. That's why it's important to go in all these areas. And use your landmark, mid-scapula, mid-clavicle, mid-axillary, you know, the lobes, is it the right upper, right middle, right lower? Be very specific where you hear these abnormalities. Also, do you hear them on inspiration or expiration or both? That's important too, okay? So I'm just gonna listen. don't just breathe normal, don't go with me here. I'm going to show you the Cliff's Notes version of moving through all these areas, okay? So don't pass out on me. So notice how I go across the spine, and then drop down, and then across, and then down. Again, I'm in the speedy version here, okay? Put your arms over your head. I'm going to listen laterally, and I'm going to compare side to side. Keep in mind that on the left, if you want to turn this way, we're going to go in kind of a C motion because of how the left lungs are laterally. Turn around again. And on the right, we're going to go in more of an S motion because of how those legs come together. Visually, do you remember that picture I showed you on the slide? How they kind of stack triangular? You need to make sure you listen to each one. But we're comparing side to side and again upper to lower. Okay, so you can turn this way. this side so that I kind of knew I left my finger there. So when I came back from comparing, I knew, okay, you need to go below that, okay? That's just something I do. I just did it. I don't recall ever saying, Sydney, you should put your finger here, okay? So that's lateral. Now we're gonna, if you could turn around, we're doing anterior. And remember, where do we start when we listen anterior? Up here. What sounds are we gonna hear up here? Tracheal, right? They're very loud, okay? Then we're gonna hear more bronchial here in the center, and then vesicular out towards the edges, okay? Or you may hear no breath sounds or decreased breath sounds. That's important to know where you're gonna hear these, yes?
When you're assessing, like on the posterior side, does it matter which side you actually like start
No,
on?
I don't care.
Just as long as
You're comparing side to side and upper to lower. That's why I said don't get caught up in the location and the number and number 1, number 2, number 3, number 4. I just need you to make sure you listen to every single area. Ms. Patterson.
You know, I do pediatrics, and what do children do with beans? They put them in their nose, and what do they do once they're in the nose? They push it further, and where does it go? It goes into the lung. I can always have a degree of disappointment when a child goes to the emergency room and people just send me a nice little note that the child's fine and they couldn't find the bean. And my question is, did they listen in all the lobes to that child? Because what will happen if a bean is occluding one of the bronchioles?
What happens when the alveoli don't get what they need? They're open. What happens? They collapse, which causes what? When the alveoli collapse, what's that called? What? Atelectasis.
So are you gonna hear breath sounds where that bean is?
Nope.
You're gonna have alive and kicking nurses that say alive and kicking physicals means I've done what Professor McCraw explained at the first, what you don't wanna do. They just put their scope on the 3-year-old and walked off and said he's breathing. We are nurses that want to give excellent care because God has brought those patients into your life to actually care for them, not get them in and get them out. So be the nurse that actually listens and says, no, I didn't hear anything in that posterior area. So,
Guys, I've been doing clinicals for like 10 or 11 years with students, and even before that, I've oriented them. I truly cannot tell you how many times my students have found something abnormal after the nurse and the physician had been in that room. Does that scare you at all, just a little? It should scare you a lot, because we're doing the right assessment, and they're not.
Yeah, I was gonna say the same thing in practice. I can't tell you how many times that I've come behind and people have said normal breath sounds, nothing there, and then I go in and I question myself and say, am I really hearing that bronchi? Just the other day, working,
Yep.
CHF patient, fluids running at 150 an hour, and I go in and listen, and I'm like, one, why are these fluids running?
Right.
At this rate, let's talk to the doctor, turn them off, crackles, I mean,
Full of fluid.
full of fluid, so you're giving them this Lasix and pumping them full of fluid, and it's
Right.
like, why are we doing that? So don't be afraid to question, what's happening for your patient, and advocating and saying, this isn't right, I'm hearing something different, get another person to come and listen,
Yep. Phone a
Because
friend.
most likely, you're right.
Yep.
yeah.
And I get this a lot from students. Ms. McCraw, I know I heard wheezing. I know I did. What do I do? Well, one, listen again, or I'll come listen. 2, chart what you heard.
Yes.
Chart what you hear, see, and feel, not what the nurses before you did, okay? And if that's what you hear, see, and feel, then that's exactly what you chart, all right? Odds are you've done a better assessment than they did. And I told you guys about my senior student right now, had a neuro patient, brain, and she went in and she thought, my patient's really not breathing that well, not even that fast. And she counted, she got 8. But she looked back at all the vital signs that had been charted, and it was 18, 16, 18, 16. It was actually 8. And then he ended up crashing and had to go to the ICU and all this, and I'm like, wow. Maybe had an appropriate assessment been done before, it wouldn't have gotten to that point, okay? So that's why we not only note the rate, but the rhythm, the pattern. We talked about bites, that abnormal, irregular, shallow breathing that we have with neuro that leads to apnea, okay? There's a reason we teach you these abnormals, is so you can recognize them and intervene before they end up trying to go see Jesus, okay? All right, so I'm gonna listen anterior. So we have our tracheal sounds, and I'm going fast, moving down into bronchial, and you guys will hear the change. Okay? And again, go slow, each full breath, but it really does change in pitch and tone, and you need to practice that now on normal, healthy people, okay? I tell you guys all the time, you might not know what it is exactly, but you know it's not normal. How do you know? Because you've assessed normal so many times, you know for a fact that's not normal. Maybe I don't know what it is, but it's not right, okay? So, that's your auscultation. So we've inspected, we've palpated, we've percussed, and we've auscultated. And then we're going to talk about, again, I verbalized what those adventitious lung sounds. We're going to verbalize the vocal resonance testing, okay? So that, again, is where you listen with your stethoscope. I'm going to show you guys, but you don't have to actually do it. But you need to talk about it to your patient, not the camera, and educate them on what these tests mean, okay? You guys need to understand what these tests are. Again, if you have percussed and you hear a little bit of like a dull sound, maybe in this right middle lobe, and then you auscultated and there was a breath, it was diminished or maybe absent in this right middle lobe, then I'm going to do vocal resonance, and it's going to be really loud over this right middle lobe. What do I think is sitting in that right middle lobe? Fluid or consolidation, guys. You're 3 for 3. So then at that point, you're only getting that chest x-ray to prove what you already know, what you already found on assessment, okay? We're not doing the chest x-ray to show, oh, that's what it is, that's what, no. You need to find it on assessment, okay? So the vocal resonance is another way to test that. Remember, when you do vocal resonance, normal sound should be what? I told you to highlight it, star it, muffled. So if it's really loud and clear, probably fluid or consolidation. And if it's really low, maybe excess air, okay? So turn on around. Bronchophony is where they repeat 99, okay? Just like tactile fremitus. And it should sound like a muffled 99, okay? So I just want you to say 99.
99, 99, 99, 99.
Okay, and you could go down. Egophony is when they say the letter E, but you should hear it as an A. Really wicked how it just changes. It's magic. Okay? Say E. Okay? It does sound like an E, but it has kind of an A sound to it as well. Okay? Then whisper pectoriloquy is a whisper. They whisper 1, 2, 3, and you can hear that whisper as you listen. To me, that's really cool. I'm literally hearing a whisper through my stethoscope, through your lungs. Okay, just whisper 1, 2, 3. Okay? And he does get a little more diminished in the bases, more the vesicular area, and I expect that, right? Think about the anatomy of the lungs and how we branch out into the tree. So that's very good. He's also very thin and fit, so the sounds resonate really, really well. Okay, so you have to take that into account as well. All you have to do is discuss those tests. Educate your patient on the vocal resonance test, but that's part of your checkoff, okay? And that's your respiratory assessment. You do get 15 minutes this week. Why? Because I want you to listen to your patient in all 26 areas for a full breath cycle without making them pass out. I also want you to take your time to percuss for diaphragmatic excursion. You only have to do one side, but I want you to truly do it. Don't just randomly put marks on their back, okay? This may be the only tool you have one day to help diagnose. You're not diagnosing, but to help diagnose your patient. You report your findings, right? Yes, Dr.
So
Fisher.
diaphragmatic excursion is only one side, but the rest is on both sides.
Yes,
You cannot
ma'am.
say that I do the same thing on the left side. Correct.
And if you aspirate or you have a pneumonia, what lobe is it more likely to be in? Right, in the right middle. Why? The right bronchus is more straight, right? So keep that in mind too, all right? Any other questions before we break apart and mark all over each other and tap on each other?